we're going to be doing the entire toxicology in today's video. Let's just get started. We're going to be talking about the general principles: corrosives and organophosphorus poisoning, metallic, non-metallic poisoning, plant toxins, inebriants and spinal poisons, asphyxiants, and snake and scorpion bites. The legal duties of a doctor: the doctor cannot refuse any treatment for a poisoning case. The doctor must preserve evidence. And under section 303 under 33 BNSS, we have police intimation. Punishments we have under 238 BNS for removal or disappearance of evidence. For 211 we have failure to inform the police, and 212 is giving false information. Medical duty: stabilization and treatment always comes first. So here we have to stabilize the patient. We have to look airway, breathing, circulation. Then decontamination: here we do gastric lavage for oral poisons and morphine. Removal of absorbed poisons through hemodialysis, or we can also give activated charcoal, which absorbs the poisons, and we give the antidote for the specific poison. And an important note is that the fastest method of absorption of a poison is through the inhalational route, then followed by IV. OPC can either have a kerosene-like smell due to the addition of aromatics, or it could just have a normal garlic smell. So all of them, phosphorus and OPC, which have phosphorus as well, smell like garlic. Arsenic also smells like garlic. Cyanide has the smell of the oil of bitter almonds. Cannabis smells like burnt rope. Chloral hydrate smell like acrid pear. Alcohol and acetone have fruity odor. Sulfur containing hydrogen sulfide has rotten egg smell, and kerosene from the due to aromatics added to OPC smell like kerosene. Lavage. Contraindications: we have absolute contraindication is in corrosive poisoning due to the risk of perforation, except in carbolic acid poisoning, which causes a leathery mucosa. We do not use gastric lavage in corrosive poisoning. Relative contraindication is if the patient is unconscious, if there is a risk of aspiration, pneumonitis, and if it may precipitate convulsions. Urinary excretion of poison. Urinary excretion of poison is used for drugs that are either acidic or alkaline. For example, if it's an acidic drug, to neutralize it, we add an alkaline. So for drugs such as salicylates and barbiturates, we add alkali to neutralize it. And drugs such as drugs which are alkaline, such as amphetamines, we acidify them. Other elimination methods, we have hemodialysis and multi-dose activated charcoal for drugs with enterohepatic circulation. The important antidotes to know for each of the poisons. For arsenic, we use British anti-leucide, or so known as dimercaprol. Copper, the antidote of choice is penicillamine. Iron is desferrioxamine. Lead, we use EDTA. Or if it's very severe lead poisoning, we combine EDTA with BAL. We need to know that BAL is used with lead poisoning in severe cases, in severe poisoning. Mercury, we mainly use BAL. Cyanide, drug of choice is hydroxycobalamin, or we can also use amyl nitrite. Digitalis, we use Digibind. Morphine, we use naloxone. Methanol, we give ethanol and fomepizole. Along with ethylene glycol, we also give ethanol and fomepizole. OPC poisoning, we give atropine and oxime such as pralidoxime. Benzodiazepine, the antidote of choice is flumazenil. And acetaminophen, we give N-acetylcysteine. Acetylene or salicylate poisoning. EDTA increases the renal excretion of the poison, therefore it is contraindicated in renal failure. BAL is not used in organic mercury, iron and cadmium poisoning. And allylisate, which is used in cyanide poisoning, contains amyl nitrite, sodium nitrite, and sodium thiosulfate. Sodium thiosulfate increases the urinary excretion of the cyanide. Moving on to morphine poisoning. Morphine poisoning clinical features, we have coma, pinpoint pupils, respiratory depression, hypothermia, hypotension. Morphine poisoning has a triad which consists of coma, pinpoint pupils, respiratory depression, and coma. The classical features of morphine can also be remembered by the mnemonic morphine, which consists of meiosis, orthostatic hypotension, respiratory depression, pain relief, hypotension, intracranial pressure increase, N for naloxone as the antidote, E. E for emesis, euphoria. We have acids and alkalis. The differences between acids and alkalis are in acids, the type of necrosis that occurs is coagulative necrosis, whereas in alkalis, we have liquefactive necrosis, except for hydrofluoric acid, which causes liquefactive necrosis. Other differences between acid is there is formation of eschar in acid, while there is no eschar formation in acid. There is more lateral spread in alkalis. There is more deeper spread in alkali, whereas in acid it's more superficial. The involvement is more gastric than esophageal, whereas in alkali there is more esophageal due to the alkalis being faster in action. Therefore, if swallowed, it affects the esophagus faster than it does the stomach. Clinical features are local in acid, and if absorbed systemic through oral route, we have systemic effects. Vitriolage is also called is acid attack. It is punishable under 124 BNS. Doctor has to provide free first aid and immediate treatment to the patient who comes with acid attack. Failure to treat a victim of acid attack, POXO, or rape is punishable under 397 BNS. Sulfuric acid, nitric acid, and phenol. These are the important acids that we have to do. Sulfuric acid, it causes carbonization, which means black eschar or necrosis of the tongue, stomach mucosa, and skin. And due to its hygroscopic action, we have chalky white teeth. Nitric acid in the body gets converted to picric acid. Picric acid, which then leads to the discoloration of the teeth into yellow color. This is called xanthoprotic reaction. Carbolic acid, or also called as phenol, it can be absorbed through all routes, including skin. It acts as a disinfectant and therefore it delays putrefaction. Ingestion causes a leathery buff white mucosa, metabolized in the liver to pyrocatechol and hydroquinone. Urine causes carboluria, which is as an olive green color seen in the urine. Black tissue, which is called as ochronosis. CNS depression and convulsion, and constricted pupil can be seen. Organophosphorus poisoning. In the acute symptoms, we have muscarinic actions which can be remembered by dumbbells. We have diarrhea, urination, meiosis, bradycardia, bronchoria, emesis, lacrimation, and salivation. And in nicotinic action, we have irritability, confusion, convulsion, and muscular paralysis. The antidote of choice in organophosphorus poisoning is atropine, and oxime we can give such as pralidoxime. Most people, we can say atropinization until the pinpoint pupils dilate or until the airway secretions are dried and clear. Therefore, then we can stop atropine. Next, we have the syndromes over time. We have cholinergic syndrome occurring initially, which is described above. Intermediate syndrome in 1 to 4 days. The We have proximal muscle weakness, cranial nerve palsy. This is due to incomplete treatment. Delayed syndrome is seen in 1 to 4 weeks, which is distal neuropathies due to slow release of organophosphorus from the adipose tissue back into circulation, which leads to a recurrence of the symptoms. The investigation of choice is RBC cholinesterase preferred over pseudocholinesterase, and treatment we just give them supportive measures. For acute poisoning of arsenic, it's the symptoms resemble cholera. We have gastroenteritis, loose stools, and red velvety stomach mucosa is seen. In chronic arsenic poisoning, we can use the mnemonic arsenic to remember. Aldrich Meese lines, seen as a transverse white nail lines, seen also in thallium poisoning. Alopecia. R is raindrop pigmentation, which is hyperpigmentation of the flexures of the skin of the palm. Skin eruption. Neuropathy, which is a symmetrical and sensory motor. And ischemia, which lead to Blackfoot disease due to gangrene of the foot. Mercury poisoning, also called hydrargism. It is seen in hatters and glass blowers. It it leads to slate gray stomach mucosa. Also causes Minamata disease due to seen in Japanese people due to consumption of organic mercury through fish. Erethism is the chro- is seen as due to is the neuropsychiatric condition caused due to mercury intake. We have tremors, acrodynia, which is also pink disease, which can be remembered as all peas. And we have mercuria lentis, which is a brownish anterior capsule. It does not cause any loss of vision. Acrodynia, we have just peas, which is peeling skin, pinkish, painful peripheries. Lead poisoning, also called as Saturnism, can be the clinical features of lead poisoning can be remembered by the mnemonic of A, B, C, D, E, F, G, which are A for anemia, which is microcytic hypochromic anemia, which due to the blockage of ALA dehydratase enzyme in the protoporphyrin pathway. B for Burtonian line, bone line, and colics. Cabot's ring. E for encephalopathy. F for facial pallor, which is the most consistent finding, and gout. The most common chronic heavy metal poisoning. The antidote is EDTA, and in severe poisoning, we have EDTA plus British anti-leucide. Next, we have phosphorus poisoning. Red phosphorus is not toxic. White phosphorus is toxic. It has luminescent properties, garlic odor. It emits fumes and has spontaneous consumption. We have acute poisoning. We have smoky stool syndrome, which is due to the phosphorescence and the smoke fumes coming out of the stools. Vomitus and stool are luminescent. Chronic poisoning is seen due to the lucifer mastic. We have if this is due to chronic phosphorus exposure leads to phossy jaw, which is osteomyelitis and osteonecrosis of the jaw. It can also be infection of the sinuses leading to pus coming out of the sinuses, which having garlic odor. Plant toxins. These are the common toxic seeds we have. We have ricin communis, which is oil is not toxic, but its residue is toxic. Abrus precatorius. It's the ideal cattle poison, and it's used in needles, and it resembles a viper bite. Semicarpus anacardium, also called as marking nut. It is used for malingering, as in fake. It is used to fake bruises. Croton, croton, both oil and residue are both toxic. It can lead to diarrhea and gastroenteritis. Calotropis, all parts are toxic. And capsicum annum leads to Hernan syndrome, which is occupational contact dermatitis. Milky exudate from unripe capsule leads to crude opium, which is the main ingredient for the poisoning. Morphine for poisoning done above. The main antidote is naloxone. Heroin, also called smack, junk, brown sugar, tar. It is highly addictive. The routes of abuse are vapor inhalation, mainlining, skin popping, and speedball with cocaine. Datura is a deliriant which causes active principle is hyoscine and atropine. It causes leads to anticholinergic effects. Therefore, the antidote is physostigmine. The roots and seeds are the most toxic, and the fruit resembles that of castor. Resembles that of castor. It is also called a stupefying. It is also a stupefying agent or a roadside poison because it is used to facilitate crime. Cannabis and cocaine. Cannabis is the most common used illegal substance. It is also called as grass, rope, hash, weed, marijuana, MJ. The active principle is tetrahydrocannabinol or THC. The preparations we have are bhang, ganja, charas, and hash oil in increasing percentages. Bhang is mixed with food, ganja is smoked. Chronic abuse can be remembered with AIR. We have A motivational syndrome, insanity, run amok. The clinical features can also be remembered by the mnemonic favorite, where we have flashback phenomenon, A motivational syndrome, vomiting, running amok, insanity, reduced testosterone. Cocaine is a stimulant of the CNS, also called as coke, snow, and crack. The most common route of abuse is snorting. Ac- Acute in excessive intake of cocaine in body packer syndrome is when there is the people swallow cocaine packets, and this leads to rupture of the cocaine packets in the body. It causes there is increase in heart rate, BP, temperature, sympathetic and dilated pupils, all sympathetic clinical features. Chronic abuse can lead to septal perforation, black tongue, and teeth staining. Peripheral gangrene due to vasoconstrictory effect. Cocaine bugs or Magnan syndrome. Alcohols. We have the most toxic being isopropyl alcohol, then followed by methanol, followed by ethanol. It is affects females more than males due to females having lower water content and higher fat content, and females having lower body mass in general. In drunkenness certificate giving a drunkenness certificate, the if there is no smell or no and normal coordination, we can say that the person is not has not consumed alcohol. If there is smell but and normal coordination, we can say that the person has consumed alcohol but is not under the influence. If there is presence of smell and abnormal muscle coordination, we can say the person is under the influence of alcohol. Wernicke's encephalopathy is remembered by the mnemonic of Goa. We have global confusion, ophthalmoplegia, and ataxia, seen due to thiamine deficiency. Korsakoff psychosis is seen in retro or anterograde amnesia and confabulation with and holiday heart syndrome, which is sudden arrhythmia. Therefore, in ethanol poisoning, we give thiamine to prevent Wernicke encephalopathy and Korsakoff psychosis. In methanol is wood alcohol. It can lead to mass poisoning such as the Hoosh tragedy. Uh, we have abdominal pain, blurring of vision, blindness due to optic atrophy. It leads to acidosis due to the toxic metabolites of formic acid and formaldehyde. The antidote is fomepizole and ethanol or ethylene glycol is radiator fluid or antifreeze. It is metabolized to oxalic acid. Oxalic acid, which then forms calcium oxalic crystals with calcium in the body, which leads to hypocalcemia. For treatment, we give calcium gluconate, ethanol, and fomepizole. The antidote strategy is the same as methanol poisoning. Strychnine and aconite. Strychnos vomica, also called as cuchilla, even one crushed seed is fatal. Active principle is strychnine. It acts on the anterior horn cells and blocks glycine, which leads to muscle convulsions and resembles that of tetanus. There is alternating spells of convulsion and relaxation, progressive worsening. The patient is conscious but dies due to spasm of the respiratory muscles. The presentation we have rhizus sardonicus due to the facial muscle spasm. Due to facial muscle spasm, opisthotonus due to hyperextended spine, and prosthotonus may be due to forward hyperflex spine and due to flexing of abdominal muscles. And pleurosthotonus is lateral flexion. Cardiac poisons can be remembered by the mnemonic of Cardona, where we have cardiac poisons. We have digitalis, oleander, nicotine, and aconite. Digitalis, the main antidote is digibind. Oleander, we have two types, pink and yellow. Which nicotine is found in tobacco and stimulates autonomic ganglia. Aconite, also called as blue rocket, metazahir, or devil's helmet. It is all parts are toxic, but root is the most toxic. Classic feature is perioral paresthesia. Coming to asphyxiants, we have carbon monoxide and cyanide. Carbon monoxide is a gas. It is lighter than air. It has affinity for hemoglobin 210 times that of oxygen. Cyanide is the gas has the most rapid onset. It is odorless, where this one has the smell. Cyanide has the smell of oil of bitter almonds or bitter almond smell. It has increased affinity for hemoglobin 210 times that of oxygen, which leads to anoxia. Cyanide blocks cytochrome oxidase, leading to histotoxic anoxia or cytotoxic anoxia. The treatment, we give hyperbaric oxygen. Whereas for cyanide poisoning, we give hydroxycobalamin or amyl nitrite. Hydroxycobalamin is the drug of choice. On hypostasis, we have cherry red color and brick red color. Snakes, families, and clinical features. We have the three main families. We have Elapidae, Viperidae, Hydrophidae. Elapidae leads to neuromuscular paralysis due to neurotoxic features, neurotoxic effects. V. Viperidae for vascular toxic. This leads to disseminated intravascular coagulation. Hydrophidae leads to it has myotoxic effect leading to myonecrosis, which then leads to rhabdomyolysis, which then leads to renal failure. Common examples are common cobra, crate, king cobra. For Viperidae, we have Russell's viper, soft-keeled viper, and Hydrophidae, we have sea snake. An occult bite may be due to crate, or history of no bite can be also crate bite as the bite is not seen. Along with neuromuscular paralysis, we give anti-snake venom. If there is a dry bite, that means there is no envenomation. There is no symptoms. We can diagnose using 20-minute whole blood clotting time. An elapid bite, blood clots normally and in clots within 20 minutes. If it's a viper bite due to coagulation, due to disseminated intravascular coagulation, no coagulation occurs even after 20-minute whole blood clotting time. There is no clotting in viper bite, whereas in the rest, in elapid and hydro, there is normal clotting. Local signs, we have pain, swelling, bleeding, necrosis, compartment syndrome, and gangrene. And in neurotoxic, ptosis is one of the earliest clinical findings, followed by descending paralysis and respiratory failure, which causes death. We need to make sure the patient does not move. We need to make sure that there is no tourniquet application or no electrotherapy. Then we can reassure the patient. We immobilize the limb by using Sutherland's wrap. We get him to the hospital immediately and tell the doctor about the symptoms. If ophiotoxemia is present, then we administer anti-snake venom. And Indian anti-snake venom is useful for the big four. The big four, which are common cobra, crate, Russell's viper, and saw scale viper. And we also give neostigmine and atropine. Scorpion sting. Scorpion sting leads to autonomic storm, which we see as sweating, salivation, priapism, hypotension, and cold extremities. And we also have hypertension, tachycardia, MI, pulmonary edema, and oliguria. For treatment, we give prazosin and antiscorpion venom. Both of these can lead to cardiac failure. Important mnemonics that were mentioned in the video. And that's it. Thank you.